Hello and welcome to the Emergency Room Podcast, the place where we delve into the fast-paced, life-saving world of emergency medicine. Are you ready to explore the critical decisions and cutting-edge treatments that happen daily in the ER?
Hey everyone, welcome to the deep dive. We're going to be untangling a topic today that I think can be a real puzzler sometimes, even for like the most seasoned ER docs. Pericardial diseases.
Yeah, they're fascinating and potentially life-threatening.
Exactly.
So getting it right is crucial.
Yeah, absolutely. We've got a great compass for this deep dive, though, the 2015 ESC guidelines.
Yeah.
These guidelines bring together the latest expert opinions on diagnosing and managing these conditions.
And they're really a game changer for staying up to date in a field where treatments are often off-label.
Yeah.
There are no drugs specifically registered for pericardial diseases.
Right. Okay, so let's set the scene. Picture the pericardium, that double-layered sac that's cradling the heart. It's a protector, a shock absorber, but also a potential trouble spot. Table 3 in the guidelines lays out the sheer variety of conditions that can hit the pericardium.
Right.
I mean, from infections to autoimmune attacks to even cancer.
And that's what makes diagnosis so tricky. The causes are diverse.
Right.
Yet the symptoms can be remarkably similar.
Yeah, it's like a medical mystery where the clues can lead you down all these different paths.
Exactly.
Now, how do we crack the case?
Yeah.
The guidelines stress a multi-pronged approach,
Yeah.
starting with a good old-fashioned physical exam.
Absolutely. Listening for those telltale pericardial rubs, getting a detailed history.
Right.
Those are your first pieces of the puzzle.
Then we layer on the diagnostics. First up, the ECG.
Yeah.
A classic sign of acute pericarditis, the sudden inflammation of the pericardium, is widespread ST segment elevation. But here's the catch, and this is a crucial one.
That ST elevation reflects epicardial inflammation,
Yeah.
meaning the outer layer of the heart muscle is involved. The pericardium itself doesn't generate electrical signals.
Right.
So the ECG changes we see are actually a reflection of what's happening in the heart muscle underneath.
That's a subtle but important distinction.
It is.
And it's easy to misinterpret. We also need to look at blood tests.
Yeah.
Markers of inflammation like CRP and ESR, along with a white blood cell count, help us gauge the extent of the inflammation.
And if we suspect the heart muscle itself is involved, which is always a possibility,
Right.
checking troponin levels is critical.
Now let's bring in the imaging powerhouse, echocardiography.
Yeah.
It's our window into the pericardium.
Exactly. Echocardiography allows us to visualize the pericardium, assess for fluid buildup, and even spot signs of cardiac tamponade.
Right.
A life-threatening complication we'll discuss later. Think of it as your real-time view of what's happening in the pericardial space.
We also have CT and CMR in our toolkit.
Right.
When do those come into play?
They provide a deeper level of detail. CT is great for revealing things like pericardial thickening calcifications or masses. CMR can even pick up on inflammation and help differentiate between different types of pericardial conditions.
So we've got our diagnostic roadmap. Now let's dive into some specific pericardial diseases.
Okay.
Starting with one we encounter frequently in the ER, acute pericarditis.
And specifically, let's start with viral pericarditis. It's considered one of the most common culprits, especially in developed countries.
So we're talking about those viruses that have particular fondness for the heart.
Exactly. Viruses like Coxsackie viruses and adenoviruses can trigger inflammation in the pericardium.
So we suspect viral pericarditis based on the patient's presentation. What's our next move?
Confirmation can be a bit tricky. The guidelines actually advise against routine viral serology in most cases.
Okay.
Because it's often not helpful in guiding our management.
So how do we know for sure it's viral?
If pinning down the exact virus is crucial, we'd need to analyze pericardial fluid and biopsies looking for viral genetic material.
That sounds pretty invasive. Is it always necessary?
Not always. In most uncomplicated cases, the clinical picture combined with basic investigations is enough to make a presumptive diagnosis and start treatment.
Okay, speaking of treatment, what's our game plan for viral pericarditis?
Well, the good news is it often resolves on its own. But we can ease the process and manage symptoms with those trusty anti-inflammatories.
Our go-to NSAIDs like ibuprofen.
Exactly. They're our first line of defense, effectively reducing inflammation and pain. Aspirin is another option, especially if the patient's already taking it for other reasons. We usually start with a higher dose, for example, 600 to 800 milligrams of ibuprofen 3 times a day, or 750 to 1,000 milligrams of aspirin 3 times a day, and taper it down as symptoms improve.
And what about colchicine? I've heard it's becoming a key player in pericarditis management.
You're right. Colchicine is a real game changer. Studies have shown it dramatically reduces the risk of recurrence, which is a major concern with pericarditis. The guidelines recommend adding it to the regimen. The typical starting dose is 0.5 milligrams twice a day for patients weighing over 70 kilograms and zero point 0.5 milligrams once a day for those weighing less.
Why is that weight-based dosing so important?
Well, colchicine can have some gastrointestinal side effects, and adjusting the dose based on weight helps improve patient tolerance and compliance.
Smart move. What about steroids? Are they ever used in viral pericarditis?
We generally try to avoid them. While they can be effective for symptom control, steroids carry the risk of reactivating the virus. Plus, they can increase the likelihood of recurrence. We reserve them for severe cases or those not responding to NSAIDs and colchicine. If we do use them, we start with a moderate dose, such as prednisone, 0.2 to 0.5 milligrams per kilogram per day, and taper it slowly over several weeks.
So NSAIDs and colchicine are our dynamic duo with steroids reserved for specific situations. Is there anything else we should keep in mind when managing viral pericarditis?
Emphasizing rest is crucial. Physical activity should be restricted until symptoms resolve and inflammation markers normalize. We need to be especially cautious with athletes, making sure they don't jump back into training too soon.
Makes sense. Now let's shift gears and discuss bacterial pericarditis,
Okay.
which presents a whole different set of challenges.
Yeah, bacterial pericarditis is a true infection of the pericardium, and it can be quite serious, even life-threatening, if we don't act quickly.
So what red flags should we be watching for in the ER?
The presentation can resemble other types of pericarditis with chest pain, fever, and the potential for pericardial effusion. However, patients with bacterial pericarditis often appear more acutely ill. We need to be extra vigilant in those with weakened immune systems or a history of recent surgery or trauma, as they're more susceptible.
So if bacterial pericarditis is on our radar, what diagnostic steps are essential?
Pericardiocentesis is key. We need to analyze that pericardial fluid to pinpoint the culprit bacteria and guide our antibiotic choices.
And I'm guessing we're going to hit it hard with intravenous antibiotics.
Absolutely. Prompt and aggressive antibiotic therapy is critical. The choice of antibiotics will depend on the specific bacteria we identify, and we may need to adjust the regimen based on the patient's response and culture results.
So drainage and antibiotics are our 1-2 punch. Are there any other treatment considerations for bacterial pericarditis?
In some cases, if there's a large amount of pus or the infection is stubborn, we might need to consider surgical intervention. A pericardiectomy, where we remove a portion of the pericardium, can be life-saving in these situations.
Okay, that sounds intense. Now let's move on to another complex type of pericarditis. Autoimmune pericarditis.
This is where the body's own immune system turns against the pericardium, leading to inflammation. It's often linked to other autoimmune conditions like lupus or rheumatoid arthritis.
So how do we go about diagnosing autoimmune pericarditis?
The presentation can mimic other forms of pericarditis, but a key clue is the presence of additional autoimmune symptoms. We'll also check for specific autoantibodies in the blood, which can point to an autoimmune origin.
And I'm assuming treatment involves suppressing the immune response.
Precisely. Corticosteroids are our mainstay here. They help dampen down the immune system's attack on the pericardium. The starting dose depends on the severity, but we often use prednisone, 0.5 to 1 milligram per kilogram per day, and gradually taper it down.
We've covered viral, bacterial, and autoimmune pericarditis. Now let's talk about a common complication that can arise from any of these pericardial effusion.
This is when fluid builds up within the pericardial sac. It can range from a small, harmless amount to a large effusion that puts pressure on the heart.
How do we assess the severity of pericardial effusion in the ER?
Echocardiography is our go-to tool. It lets us visualize the effusion, measure its size, and determine if it's causing any problems with the heart's function.
And how does our management strategy change depending on the severity?
If the effusion is small and not causing any symptoms, we might just watch it closely with serial echocardiograms. But if it's large, causing symptoms or affecting the heart's ability to pump effectively, we need to step in.
What kind of interventions are we talking about?
Pericardiocentesis is often the first line of action. This involves using a needle to drain the fluid, providing quick relief.
Are there situations where pericardiocentesis might not be the best option?
Yes, there are a few scenarios. If the effusion is trapped in pockets within the pericardium, making drainage difficult, or if it keeps coming back, a surgical approach might be necessary. Creating a pericardial window allows the fluid to drain continuously.
We've talked about the potential for pericardial effusion to become a serious problem. Now let's discuss the most serious complication, cardiac tamponade. It's a true medical emergency, isn't it?
Absolutely. Cardiac tamponade occurs when the pressure from the fluid in the pericardium becomes so high that it squeezes the heart, preventing it from filling properly. It's a life-threatening condition requiring immediate action.
So what are the telltale signs we need to recognize quickly in the ER?
The classic triad is hypotension, muffled heart sounds, and jugular venous distension. But it's important to remember that not every patient presents with all three signs, and time is of the essence.
Meaning we don't wait around for confirmation if we strongly suspect cardiac tamponade.
Exactly. If our suspicion is high, we move straight to pericardiocentesis.
Okay.
This procedure, by rapidly removing fluid from the pericardial sac, can be life-saving in this scenario.
It sounds like a delicate procedure.
It is. That's why echocardiography is so crucial for guiding the needle and ensuring we're accessing the pericardial space safely and effectively.
It's amazing how echocardiography plays such a vital role throughout the diagnosis and management of pericardial diseases.
Yeah, it's a real cornerstone of our approach, giving us a dynamic, real-time view that guides our decisions every step of the way. Let's switch gears now and delve into another challenging pericardial condition, constrictive pericarditis.
This one sounds particularly tough on the heart.
It really can be. Imagine the pericardium, instead of being a flexible, accommodating sac, becoming thick and rigid, almost like a straitjacket encasing the heart.
So it restricts the heart's ability to fill with blood properly.
Exactly. The heart is literally squeezed, and that can lead to a whole host of symptoms. Fatigue, shortness of breath, even swelling in the legs and abdomen. It can easily mimic heart failure,
Yeah.
making the diagnosis tricky.
So how do we tease apart constrictive pericarditis from other conditions, like restrictive cardiomyopathy? They seem to present quite similarly.
That's where our diagnostic skills really come into play. Echocardiography can give us some hints,
Okay.
but often we need to bring in the heavy hitters, CT or CMR.
Right.
These imaging modalities allow us to visualize the pericardium, assess its thickness, and see how well it's moving.
And if those imaging studies still leave us unsure,
Cardiac catheterization can be the deciding factor. By directly measuring pressures within the heart chambers, we can look for the characteristic pressure patterns that are the hallmark of constriction.
so we've confirmed constrictive pericarditis. What's our treatment strategy?
Unfortunately, unlike some other forms of pericarditis that respond well to medications, constrictive pericarditis often requires a more aggressive approach.
You're talking surgery.
Exactly, pericardiectomy. The surgical removal of the thickened pericardium is the gold standard treatment for chronic constrictive pericarditis. It's a major procedure, but it can dramatically improve symptoms and quality of life for these patients.
Now let's talk about some special considerations. How do we manage pericarditis in patients with other health issues like renal failure?
Patients with kidney disease, especially those on dialysis, are more prone to pericardial effusion. And it can be a real challenge in this population.
Why is that? What makes it so tricky?
These patients often have fluid overload, which can worsen the effusion. Plus, the effusion in renal failure patients tends to be bloody, which makes using anticoagulants risky. We have to carefully weigh the risks and benefits of each decision.
It sounds like a delicate balancing act. Are there other special scenarios we need to be aware of?
Absolutely. The ESC guidelines highlight several unique situations. For example, post-cardiac injury syndromes like Dressler syndrome can occur after a heart attack or heart surgery.
So the body's own immune response triggers pericarditis in those cases.
Precisely. It's an inflammatory reaction to the initial injury. Thankfully, these syndromes are less common now thanks to improvements in cardiac care. When they do occur, we treat them with anti-inflammatories, often adding colchicine to prevent recurrence.
What about cancer patients? I imagine pericardial involvement can be a significant concern.
You're right, cancer can spread to the pericardium, leading to what we call malignant pericardial effusion. The focus in these cases often shifts from curing the pericarditis to managing symptoms and improving quality of life.
So we might use pericardiocentesis to relieve symptoms, but a cure might not be achievable.
Sadly, that's often the case. But we can still do a lot to help patients feel better and maintain their quality of life.
Let's talk about a condition you mentioned earlier, chylopericardium. What exactly is it and what makes it so unique?
Chylopericardium is a rare type of pericardial effusion, where the fluid is rich in chyle, a milky fluid filled with fats and lymphocytes. It's usually caused by damage to the thoracic duct, a major lymphatic vessel.
That's fascinating. What causes that damage?
It can be from trauma surgery or even tumors. The key is to identify and address the underlying cause. If the thoracic duct is damaged, we may need to repair it surgically. In the meantime, we can manage the effusion with drainage and dietary changes to reduce chyle production.
It's amazing how diverse pericardial diseases can be. We've covered a wide range from common to rare, and it's clear that taking a tailored approach based on each patient's individual circumstances is critical.
Absolutely. And staying up to date with the latest guidelines and research is essential for delivering the best possible care.
We've discussed many complex and challenging cases. What are your thoughts on the future of this field? What unanswered questions remain in pericardial disease management?
That's a great question. Despite the progress we've made, there's still a lot we don't know. For example, we've seen how effective colchicine is at reducing recurrence, but we're still figuring out the optimal dosage and treatment duration.
Right, and we're still learning about the long-term effects of repeated bouts of pericarditis
Yeah.
and the best ways to prevent those long-term complications.
Precisely. Plus, there's ongoing research into new treatment options, especially for those challenging cases that don't respond to conventional therapy.
So the future of pericardial disease management holds a lot of promise.
Absolutely. With continued research and innovation, we can strive to improve outcomes for our patients and further unravel the mysteries of the pericardium.
So we've really journeyed through this intricate world of pericardial diseases, haven't we? From those common presentations to those rare and complex scenarios.
We've seen how a systematic approach grounded in the latest ESC guidelines can guide us towards an accurate diagnosis and effective management.
Absolutely. And how crucial it is to recognize those red flags
Right.
that signal potential emergencies,
Yeah.
like cardiac tamponade, where prompt action can be life-saving.
Absolutely. It's a field that demands a blend of clinical acumen, a deep understanding of the pathophysiology, and a willingness to adapt our strategies to each patient's unique circumstances.
Speaking of adapting, we've discussed how managing pericardial diseases often involves navigating the nuances of coexisting conditions.
Right.
Like whether it's adjusting medications for our older patients or carefully weighing the risks and benefits of anticoagulation in those with renal failure, or recognizing the unique considerations in cancer patients.
Yeah,
It's all about personalized medicine.
absolutely.
And despite all the advances we've made, there are still unanswered questions and areas ripe for further exploration.
Absolutely. The optimal use of colchicine, the long-term effects of recurrent pericarditis, the development of novel therapies. These are just a few of the areas where research is ongoing.
It's a reminder that our understanding of the pericardium and its diseases is constantly evolving, and we as clinicians need to stay at the forefront of that evolution.
It's a dynamic and challenging field, but it's also incredibly rewarding to be able to make a real difference in the lives of patients facing these often complex conditions.
Well, as we conclude this deep dive, I'm left with a sense of awe at the intricate workings of the pericardium and a renewed appreciation for the importance of staying informed and adaptable in our approach to pericardial diseases.
And a sense of optimism for the future as research continues to shed light on the mysteries of the pericardium and pave the way for even more effective treatments.
Thanks for joining us on this deep dive into the world of pericardial diseases. We hope you've gained valuable insights that will enhance your practice and empower you to provide the best possible care for your patients.
Until next time, keep those minds sharp and those hearts open.